So thank you. Before I start, I have to say that our work has been made very easy because a lot of the contentious issues regarding the management of PUV have already been covered. So what we will try to do is proceed a little faster, and we will try to focus on an overview of PUV rather than delve into very small nitty-gritties, which I think has already been done. So we are going to take this topic literally. So journey we are going to talk about. We are going to focus on this journey. And before Ashok Das scolds us, I will make the claim that each and every child is managed very closely with our pediatric surgeons. We do not dare to manage these patients on our own. The panel consists of Dr. Kulkar, who is a pediatric surgeon, Dr. Girija, who does a lot of our pediatric nephrology ultrasounds, and the rest, Dr. Tathavatu, Dr. Shumantru, Dr. Niladri, myself, we are all pediatricians and pediatric nephrologists. So obviously this panel is going to have a little bit of a medical, it's going to have a focus on the perspective of the pediatrician and the pediatric nephrologist. So we are not going to go very much into surgical issues, we are going to touch on them, but we are going to really talk about what we need to know from the surgeons as well. So the little bit that the medical people need to know, so that these people do not fall through the net, so that they have the best possible outcome as we work as a team. That is going to be the focus of this panel discussion. So I like to start this panel, which I've done a few times before, with this patient. This is a child who was initially, when he came to us, a 1-year-old boy referred with a history of 2 febrile UTIs. Now, as you should be doing, if you have recurrent UTI, you should be looking very carefully at, addressing the juniors here. You should be addressing very carefully why is this child getting recurrent UTIs? Is there something wrong with his renal tract? So, a very careful history and examination was done, and a careful history revealed that there was a very definite history of a poor urinary stream. On examination, a suprapubic mass was definitely palpable. Initial studies revealed a creatinine which was significantly high, 2.5, and you can see, cutting a long story short, that imaging studies revealed characteristic signs of a posterior urethral valve. He underwent fulguration, there was improvement overall, the urinary stream improved, his serum creatinine started coming down. This is a child who had come to ICH, and as is routine, he was counseled very deeply, in great detail, about the importance of follow-up. Despite this, he failed to turn up and attended again at 6 years of age, and at this time, this is what he looked like. So he had short stature, bony deformities, and a creatinine of 4.6. Now, I know this is mostly a pediatric nephrology audience, but then many pediatricians, I think, are still under the opinion that once you have done the surgery in a patient with PUV, much of the threat to the child has gone. So if that is true, then why has this child done so poorly? So even though he had PUV fulguration, why has he got these CKD features? So this question goes to Dr. Tathavatu.
Thank you, ma'am. Actually, the disease of posterior urethral valves is a bad disease to have and an equally bad disease to manage by both pediatric surgeons and pediatric nephrologists. Why so? Because there is already damage to the kidneys, because the kidneys are inherently dysplastic. So that is one reason that despite the ablation, the problem has persisted. The second problem is maybe the child is having persistent urinary tract infection which has been missed. The third problem is the persistent bladder dysfunction, or the fourth problem is, as we have discuss this slightly controversial topic that maybe the surgeons have missed a few valves and it was an incomplete valve ablation, and there is a because of the dysplastic kidney, there is a reduced nephron mass which has led to inherent progression of CKD, and finally there are certain children who, despite doing everything, they are more prone to progress to CKD. So these are the 6 problems that could have led to this child. The most important was that he was not in follow-up, but these are the 6 things that could have led to progression to ESRD or CKD5.
So yes, so PUV, even after fulguration, there can be a lot of reasons for the child to not do so well. So we would say that the journey of the PUV child does not end with fulguration in every day. In fact, it only starts with the surgical procedure of bladder. When do we suspect PUV? Antenatally, I think this has been very well covered previously. Girija, do you want to say anything extra?
It has been said that I think the PGTs they were not there when we discussed it in the morning, so I'll just go through it very briefly. When we do an antenatal scan, the urethra is not supposed to be seen. So if we see a posterior urethra dilated, and we can sometimes pick up the valve if we are very lucky with the 3D reconstructions, then we can make a diagnosis of a dilated posterior urethra with a PUV. But that is very rare. We usually see a distended bladder, which we call as megacystis, and there are certain nomograms for the height of the bladder, which we consider as the upper limit of normal in the first trimester, second trimester, and third trimester, which are respectively 7, 20, and 30 millimeters. So if we see any bladder which is more distended than that suggests an obstruction in the lower urinary tract. Then the bladder wall, if it is very thick, like normal is less than 2 millimeters, if it is more than 3, then we again call it a thick wall bladder. We can get the dilated ureters. Usually ureters are not seen, so if we can get to see the ureters in an antenatal scan, that also would suggest lower LUTO. And when we look at the kidneys, to look for the hydronephrosis, and we also have to look at the renal cortex to see whether there is an echogenicity, whether the cortex has thinned out, and whether there are any renal cysts, etc., to suggest any progressive disease. So renal dysplasia. Then again we have extrarenal signs, which are the oligohydramnios, and we can get IUGR because of the increasing oligohydramnios. We can get pulmonary hyperplasia, and we can get sometimes the Potter fishes and telipus and limb deformities, etc., which suggest very gross oligohydramnios actually. So these are the things which we need to look in the antenatal scans.
Okay, and I think Dr. Sudarshan has also mentioned some urinary leaks may be there.
Yeah, sometimes a calcium rupture occurs, so we get the perinephric collections, urinomas. Sometimes a bladder might rupture in extreme cases, and extraperitoneal rupture with bladder can cause a fetal ascites, as Dr. Suresh has already mentioned. And,
right. So I think the antenatal findings have been covered in good detail. Neelamji, sometimes we miss these children come to us not having had a good antenatal follow-up. They come to us in later infantile or childhood stage. In those cases, what are the presenting features?
Thank you, ma'am. That's very important because these children often present with us with poor stream or dribbling, or the child is straining while maintaining the stream. There could be recurrent urinary tract infections. Even we get failure to thrive, and if we investigate, we get underlying chronic kidney disease. And also, while in the clinic, while examining, we might get a palpable bladder mass, something like that.
Okay, so these are the usual signs and symptoms of how these children would present. When we have a suspicion, a clinical suspicion or ultrasound suspicion that this child might have PUV, Shumam, the question is to you. How should we manage these children early on? What are the steps even before we make a confirmatory diagnosis?
Okay. So first of all, thanks to ICS team for the nice showcase. Coming to the point, whenever we have a suspicion antenatally that the child may have some lower urinary tract obstruction, so post on day 1 of birth, first physical assessment, if we have any doubt that the bladder is full or something clinically, or if you have doubt and we have feasibility of doing ultrasound, we can do the ultrasound per se on day one itself just to look for the bladder. If the bladder seems to be full, just decompress it. So many a times we pediatrician can do it, but in any case of resistance, better to ask our pediatric surgically to do the same, because there might be abnormal urethral anatomy, difficult to passing a catheter. Then one decompression is done, then we need to know what are the emergencies here. Either a septic emergency due to the sepsis, which is unlikely if there is no antenatal amniotic fluid leak, etc. Or there may be some renal dysfunction emergency that can be AKI on CKD or CKD alone. So these two emergencies have to be addressed first. Better to address first prior to do the proper management of ultrasound proper. So for urology, it is there. Decompression first, then catheterization is itself a treatment, then the antibiotic, which is either by the institute protocol or by as per the culture report comes up to 3 days feasible, successfully managed. And for the AKI, the metabolic abnormalities, hyperkalemia, whatever is there, better to manage that. If the creatinine seems to be high on day one itself, that is maybe erroneous due to the maternal reflection. We need to check a drop down effect of that one, and if they are more or less stable, we can go for a final diagnosis and then the management. And then the diagnosis will consist mostly of an micturating institutional drug, which can be done as early as feasible if it is not infected, and most of the cases this is not infected on day one. And if it suggests that there is some suggestion of PUV or doubts of PUV, we go ahead. If the body weight is more or less okay and feasibility of doing a conversion go and cystoscopy and ask our pediatric surgery team to do the further procedures.
So as has been said, we need a postnatal ultrasound and we would like to have an MCUG to confirm the diagnosis.
So for male child, day one ultrasound can be opted if it is feasible, at least for the bladder part. If not, we are
Especially if we have had an antenatal strong suspicion, then I'm sure we would be prepared in this case with proper facilities.
So ultrasonography should be the first imaging modality because it's, first of all radiation is not there. And
so I think
also
before we discuss this, another important thing to stress on is that when we are planning where this child is to be delivered, we should also try to plan to deliver this child in a center where
all facilities should be available. And so if we just confirm by ultrasonography first to see that of course whatever we saw in the antenatal state matches, then we would proceed to doing the MCG within 48 hours or as soon as possible, whatever earlier possible time. And even for the ultrasonography, all the postnatal scans usually are done beyond 48 hours. Routinely we don't do it before that. But these are the cases where we would like to do as soon as possible so that we don't delay. And that is the first imaging modality. And once we confirm, we go ahead with the MCG. And as this shows, there are diverticulars.
Yeah, so the MCU confirms. And I think what Dr. Ashok Basu has been stressing all along is that these MCUs should be done by experts so that we should not make an already difficult situation worse by either injuring the valves or by inserting an infection. So coming to our surgeon, Dr. Kuntal, once we have confirmed the diagnosis, what is the step to do?
There are various methods of ablation. One is cystoscopic fulguration, one is transurethral dissection of valve, another is by wood knife incision is made, and other methods are laser ablation, Fogarty catheter, by Fogarty catheter. That depends on institution protocol or surgeon's preference. In cystoscopic fulguration, we introduce a cystoscope, and through the working channel we introduce a Buckby electrode and we touch the valve and fulgurate. But in resection we have to introduce a resectoscope. We hook the valve and resect the valve. The problem is the smallest size resectoscope is available only 9. So in smaller babies like less than 2.5 kg, we cannot introduce a resectoscope. In those cases, we fulgurate the valve by introducing a cystoscope.
And I think you said that you had mentioned before that the resectoscope is what is meant by ablation.
Ablation, over ablation. Ablation means destruction of the valve. That there are various procedures of fulguration. One is resection, another is incision or laser ablation. These are the procedures.
Is there any evidence that any one of them is better than the other?
No. In experience, and all are equally effective.
What about urinary diversions like vesicostomy or uretrostomy?
If there is a very small child, actually 1.2 kg, 1 kg, their smaller size is a cystoscope we cannot introduce. Then we have to go for a vesicostomy. And other indication is even after fulguration, and if the upper tracts are not dilated, even after fulguration, the uterus or cyst, we can go for a vesicostomy.
Okay. What about uretrostomy?
But if the upper tracts are dilated and tortuous, if the baby is in urosepsis, we have to go for a uretrostomy.
So things are not getting better by
Yes.
bladder drainage, they will be
We go for it.
considered
It
or
was-
higher. Okay, so now let's consider that the valve fulguration has been performed. What are the things to look out for in the immediate post-operative period?
Yes, the immediate post-operative period, there is very important, there is analgesia and also maintain the hydration. Because of we need to keep in mind the different dyslipidemias that immediately follow the PUV fulguration. And the presentation is varied, that is the child can have a polyuria, but you need to maintain the euphoric status. The child may go into a type 4 kind of status where the child will be having hypokalemia. And even due to the tubular dysfunction, there could be a pseudo-hypotensial like state where the child will be having hypokalemia along with that low sodium level. So definitely maintaining the euvolemia and also correcting the dyslipidemia for the initial first 3 to 5 PUV is very, very important.
And acid-base balance also. Dr. Kuntal, what about the surgical aspects? Antibiotics, is there a worry about hematuria? How long to keep the catheter in?
We usually give antibiotics for 3 to 5 days, parenteral antibiotic, then discharge with an oral antibiotic. But if the baby is in urosepsis, if the baby is very bad in sepsis, then maybe we will have to give parenteral antibiotic for 8 to 14 days, then discharge with an oral antibiotic. Regarding the surgical issues, yes, hematuria often, but hematuria usually subsides within 2 to 3 days, and we remove the catheter either within 2 days or on the third post-op day.
And when we are planning discharge, when the child has come out of all these issues, when we are planning discharge, what kind of advice do we give the parents? When should they watch out for? When should they come back for review?
After the catheter is removed, we discharge the patient if there is no straining. But if there is straining, we again reintroduce the catheter and keep it for another 3 to 5 days. So at the time of discharge, you have to tell whether the baby is straining, whether there is incomplete emptying, there is retention of urine, there is palpable mass. So these are the look after. And in the first post-op review, we usually done, if there is no problem, we usually first post-op review is done at 1 month of age. We usually do an ultrasonography to see whether there is post-void residual urine or not, and what is the status of the ureters.
Thank you. Subsequently, through the first year, I think we monitor fairly closely to see how these children are doing. And if they're doing well, we can delay the gaps between monitoring. And if they are not, then we have to plan how to intervene, what investigations to do. So for routine follow-up, Dr. Tathagata, when they are coming to you initially, what kind of clinical and biochemical monitoring are we looking at?
So, the routine follow-up of a child who has undergone a valve ablation involves the 3 things. One is renal monitoring, the monitoring of the bladder health, and the growth. So, in the clinical part of it, we have to look for fluid intake and output, whether he's got polyuria or oliguria. Then we have to look for evidence of UTI in the form of any fever, any dysuria, any vomiting, and then we have to monitor the growth of the child, because as we saw in the first case that the child apparently had progression to CKD, so growth is important. And also we have to look for the bladder function in the form of whether he is having any bladder dysfunction in the form of dribbling, in the form of any PVR and all those things. So this is the clinical monitoring, and as you mentioned in the slide, biochemistry. So we have to look for the creatinine, a baseline creatinine, and then every 1 to 3 months we have to repeat the creatinine and to see whether the creatinine is going up or down. Then we have to do the urine culture and the urine protein creatinine ratio. So these are the things that are
And it
important.
is the timing of these towards the end.
Yeah, and
These are all these are the principles of the follow-up
Yeah.
of monitoring in the first year. Dr. Imaging wise, what are the investigations that should be done? I know you are an expert on ultrasound, so maybe you will tell us how we expect these kidneys, these bladders to change gradually with time over the first year.
So what I've seen is because there is some element of bladder dysfunctions which happen after because of the disease process and surgery. So when they come, sometimes we find that the bladder has become very spastic, like it's not filling. So we find that when given a lot of time to fill up the bladder, the child keeps drinking, but then it keeps dripping also. So it is very non-contributory. That kind of a bladder where the pre-void bladder volume is maybe less than 30 or something, that is not going to help us, because the bladder wall will invariably look thick in those cases, because there's a minimum amount of bladder volume which we need, the urine in the bladder, to measure the bladder wall, because otherwise, falsely it appears to be very thick. So sometimes, some cases we fail to get the adequate pre-void filling. So those are the bladders with very low compliance or very poor filling. But in some other cases we find that there is a very hypoactivity. So in those cases we find the bladder keeps filling, and we find very overtly distended bladders.
So this is in the first year. So
Yeah.
what about the dilatation that was caused?
Okay, initially the first
How do we
follow-up,
expect that?
the first follow-up we usually look for persistence of the dilatations. We measure the various measurements as I said earlier, so we can find that maybe they are all persisting, which we expect that they don't actually revert so soon. So we don't over expect everything will be reverting to normal. And sometimes if the valves are incompletely ablated, then we might find that there will be a progression of the disease process. That is where, which is very alarming, we might need a check cystoscopy in those cases. So and some cases we find that even by few decimals, it might be regressing, which is very encouraging to us. So initial first follow-up, we always go by the measurements and we just see how it is responding. And post-void residue
Basically, I think from what you are saying, that we should be really careful about whether things are getting worse.
Yes.
But we don't expect the dilatation itself to get better very quickly.
Yeah, because the parents ask, they expect miracles. Surgery has been done, they feel everything will become normal. So they say, like, is it still dilated? So we have to tell them, we have to reassure them that you cannot expect miracles in a month or two. Basically, this might persist like this even for 1 or 2 years. So we don't expect that it will go back to absolutely normal. That's something which we need to keep telling them, because they expect, that everything will be absolutely as normal as any other child. So that is where the first follow-up matters.
So Dr. Kuntal, would you take the other imaging parameters? Where do we need to do them at any specific time in the first year? Repeat MCU, DMSA, DTPA? Or do we look for residual valves in all patients by some other method?
Regarding MCUG, we repeat MCUG if the symptoms persist. If there is straining, if there is dribbling or retention of urine, we do MCUG, and then immediately on the same day or on the next day we do a chest cystoscopy to see whether there is residual
This
valve.
is after how long?
After about 3 months.
3 months.
Yes.
Okay.
Routinely we do a chest cystoscopy 3 to 6 months, and at the same time during chest cystoscopy we resect the valve if it is present, and we do circumcision in all cases.
Do we need to do a nuclear isotope scan?
Yes, we do perform a DTPA scan at 3 months of age to see the baseline function, and DMSA.
Is this a must that
Yes.
everybody is doing it?
Yes. And we do DMSA if there is persistent reflux to see the scarring. Yes.
Next, coming to something very interesting, Dr. Shumonsra. So I think there are some parameters by which we can assess whether these children are going to have a good outcome or a bad outcome. We can, have a guess. Can you tell us about these parameters?
Right, ma'am. As you rightly said, that despite of doing everything on day 2 for regression by whole life, fortnight, XYZ, everything, still they will end to ESRT very soon and a transplant. So how can we guess that? So there are some rough ideas. Studies have shown that many of the parameters are over in different studies. Many people say that age might be a point, early age of presentation or late age of presentation versus previous history of recurrent UTI versus how is the bladder dysfunction is there by default. So all these points, summing it up, the main points are the Nadir criterion. Whatever the criterion after the bladder dysfunction within first week, that might signify a good outcome if it is less than 1 milligram per DL at that infant age. But if you fine tune that value, many times that's shown that if you take it around approximately 0.85 or 0.8 like this value, then the sensitivity might increase to catch up this poor prognosis or bad prognosis. And we can stratify the kids also. If the creatinine, Nadir creatinine, if less than 0.4, 0.44, that carries a good prognosis most of the time. And if it is more than 0.85, the Nadir creatinine to start with, then it might carry a bad prognosis. This is just a rough idea. The other things can be whatever may be the history of recurrent UTI, sometimes if there is any pop-up mechanism present or not, or many times how is the bladder dysfunction. But for a note, this age of onset of whatever is written there, that usually applies to those study where most of the kids are already catched by 5 or 6 months. But in our part of the world, many times this PUV may land up to us at 5 years of age or 10 years of age. So we don't have any idea. So for by default, another creatinine is a single point that we need to remember for a bad outcome or a good outcome.
So, okay, Nadir creatinine, but increasingly also I think we all recognize that severe bladder dysfunction can be associated with a poor outcome. Bladder dysfunction, you can see the picture of a really bad bladder on MCO in a PUV child, in a fulgurated PUV child. So the bladder assessment becomes all the more difficult because it is constantly changing, isn't it? So Neelakshi, can you tell us how the bladder changes, the spectrum of bladder changes as the child grows?
Yes, the journey begins antenatally. So you must know that there is an inherent dysfunction of the bladder musculature. So initially it starts with a very spastic bladder, poor compliant bladder, low volume or low capacity bladder, and eventually it will superseded by tubular dysfunction. The child will be presenting with polyuria, will be nocturnal enuresis, there will be recurrent UTIs, there will be incontinence, and eventually the volume of the bladder will improve. There will be large capacity bladder. Even the compliance will also improve, but that is a red flag sign because the bladder is ultimately going into a myogenic failure.
So Tathagata, when do we suspect bladder dysfunction? So not all children are going to have bladder dysfunction, right?
No, whenever there is weak stream or a high PVR or a child is having some kind of a difficulty in straining, that is. So all those things will point to a bladder dysfunction, and then we have to take certain steps in the form of
I think the point to note also is that some children might not have any symptoms.
yes,
So
sometimes it may be
routine follow-up, even if children do not have symptoms, probably like our first patient 1, even if they do not have symptoms, then even then a regular, at least non-invasive urodynamic screening with ultrasound, with looking at post-void residue, bladder wall thickness,
and a bladder diary.
Yeah. Maybe a urethrometry. I think even if they do not have symptoms, we had some cases, but I don't think we will discuss those. But I think this is also something to remember that not all of them will have symptoms. Tathagata, if you could just list, I think the audience knows all this and it has been said several times. If you could just list the different types of bladder assessment that is available to us.
The person who does all my bladder dysfunction is sitting across my, and she is my guru. So the basically uroflowmetry is a non-invasive way of finding out bladder dysfunction, in which nothing, just the child is made to pass urine, and it is electronically recorded, and in that we can find out the urine stream, and then along with ultrasound we can find out the PVR and any retrocell underactivity can be found out from uroflowmetry. And then there are non-invasive UTS in the form of a bladder diary and an ultrasound. and then we have
Finally, you say
invasive
you saw
uterus.
several examples in the
Yes.
previous cases. Anything you want to add?
I would like to highlight some practical points which I see while scanning these children. So, first and foremost is the radiology should have a lot of patience while doing these scans, because they are not going to report when the bladder is going to be full. We need to take them time and again to see whether they are having enough distension. As I said earlier, like they might have a very spastic bladder and we may not get enough bladder filling. We need to give them a chance to sit for some more time. Despite several attempts, still we don't find the bladder full. Then we are forced to report that the bladder wall looks thick, but that is again spurious because that is a overestimation of what is there, because the bladder is not adequately full. Then you mentioned there is a low compliance bladder and bladder wall appears thick like it will be due to the inadequate subabdominal bladder distension. This is one scenario. The second one is we might see that they are in a severe urgency and they keep coming and they are actually not full, but they are just the older kids. They might say that it's time for them to go to the washroom, but actually we don't find them full. And there's another scenario where they're going on sitting and we just ask, they're not having any urgency, but we take them, we find they are overfilled bladder, and we find that bladder is really too distant, and we tell them go and pass urinary, come back. And they go and in a rush they come back and we find still a large residue. So in that case also we have to have a lot of patience, give them more chance to go second void, third void. Sometimes we see, give them chance, but sometimes they have a lot of straining and they don't pass enough. Some of them just because it's a mood, they just go to the washroom and come back, they don't really, so the kids need to be given their space and time. And the fourth aspect is, if we are very lucky and the child gets very irritated because of the gel and all, they scream and they pass urine while we are scanning, and that's the most beautiful situation, because in that case, if there is still a dilatation of the posterior and some residual bulge, we can see it the best while we are voiding. So the voiding ultrasonography, I simply love it, because sometimes we can pick up mild reflux also at that time, which was not visible in the scans. So, and when we put a color flow, we can sometimes see the reversal of the color because we don't have the access to the contrast ultrasonography. So this is one way we can prove that there is a reflux. And at that point of time, we find that the diameter of the urethra also, all of a sudden, if we can measure, we do a dynamic scanning, we can pick up the reflux. So these are the things which I think
find practical.
practically we are.
Interesting, because it's very easy for us to order an ultrasound. But the amount of, and Tara was talking about, people doing lots of ultrasounds and therefore not being able to report them.
That is why I do the pediatric scans on specific days. I give them appointment. I don't allow flying cases. I give them appointment because on one day, I know how many kids I can scan, because one pediatric scan I think takes 3 scans that time. It's actually, you need a lot of patience.
This is the amount of sort of time and effort
you need a lot of
that
time.
we need from members in the team.
And they need time also. They need to get adjusted to you and your scan room, and so that they allow you to scan also. Because we don't sedate them, so you need to give them that comfort zone.
So, Shamantra, we spoke about the changes that the bladder goes through, but when we are assessing them, the common patterns, I think, are the ones that I have listed here. Would you want to talk about these patterns?
Already Bosta told about that. So number one, we usually start basically with the bladder acting against the obstruction. So might be spastic bladder, can be defined by our ultrasound and UDF. The second one, there can be some, after clearing the PUV, there might be some residual bulb of the neck, can have dysfunction, because this child might leak intermittently. They try to make their bladder neck much tight. While doing voiding also, there can be a DSD, that is detrusor sphincter dyssynesia. There on long run, the bladder can go, after a long pressure effect, they can go to myogenic failure. The myogenic failure can be due to the long-term drugs, hydrogen drugs like propane or something else. And there can be a huge bladder neck hypertrophy that can also be visible in other than ultrasound in the MCU also. So many a time our surgical team might go for a neck incision plus minus. So these 4 patterns are mostly there. They comes maybe one after another, but they might jump off those steps.
Thank you. Next, let us go to some of the problems. So now, till now we have spoken about how we should assess the children longitudinally during their journey after being detected with PUV. Sometimes along the journey they come to us with specific problems. One of these is a recurrent UTI, has been discussed in the previous case also. Prabhavata, can you tell us what is the significance How should we take this forward?
Uh,
Very
re-
short because it has been discussed.
Recurrent UTI, the significance is very important in the form of that it can indicate that there is worsening renal damage. Then it can indicate that there is significant bladder dysfunction and again an indicator of incomplete valve ablation and growth. So these are the three things, the four things that are important as far as significance is concerned. How do we investigate? We generally do a urine culture as usual and an ultrasound, and that will give us the specific organism and we treat accordingly. And
According to findings, we
yes.
proceed. Prophylactic antibiotics?
Yes, prophylactic antibiotics should be given and approximately 1 to 2 years, and or whenever the bladder function is normalized and the child is not straining and there are no further incidences of fever. So that is
So to me, a recurrent UTI seems to indicate that there is stasis somewhere.
Yes.
Urine is collecting somewhere. So why is it collecting? We can treat the UTI, we can give prophylaxis. But I think along with that, we need to think, where is the urine collecting? Why are there UTIs? And we need to address those issues. Circumcision, I think, has already been addressed. There has been an RCT to show that there is a significant reduction in recurrent UTIs in PUV patients after circumcision. So this is something that can be offered.
it can be offered, but there is a cultural thing to it. But I think we can do it as far as, because the evidence is there that meatal growth of organisms can be prevented by doing the circumcision.
Niladri, a child comes to you having been well for a few years and now has developed now complaints of delayed toilet training, incontinence, dribbling, straining, post-stream. What do you do?
Definitely, before doing it, we need to understand the significance of it, because it's often a grown-up child with always developing incontinence and straining has got a significant psychosocial aspect. So there are two heads under which I want to talk that regarding the investigations and intervention. One is the bowel management before going into the bladder, because of there is a significant relationship between bladder and bowel management. And regarding bladder management, we first go with bladder tidying, which is the most important, and not this is tool we have got, along with the ultrasound, and accordingly whatever inference we draw, we move further regarding that.
Dr. Kuntal, some children have persistent hybrid urethral nephrosis for a long time. Some children present with increasing hybrid urethral nephrosis. So first question is, when is regression? The initial validation, when is regression expected? We know it's late.
Regression is not expected at least before 2 years of age.
After 2 years, you should see some improvement.
Yes.
But if it is persisting and if there is increase, then
The possible causes are post-surgical stricture, residual valves, there will be chronic hypertrophy, there will be PUV obstruction, and persistent PUV, and also bladder dysfunction.
so again we need to proceed along the path of bladder assessment
Yes,
to
bladder
see
assessment.
which one of this
And
is
we have to
being
manage
used
this case.
and manage accordingly. Coming to Shumantra, in this day and age, even in very modern centers where there is very good bladder care, follow-up and monitoring, even there they report 20% ESKD in these children by the time they reach adolescence. Why is that?
As Dr. Host told in the first slide that not by the time they reach adolescence, by the time they are born, they might have some inherent bladder kidney related issue that can be either in the glomerulus, that can be in the tubules or in the interstitium. The damage might already been happened just at birth or before that. So we need to ascertain for the part of post-treatment follow-up care, the polyuria part, the tubular damage part, the most nearest tubule to the outflow obstruction is the distal tubule. So we might face some type 1 RTA, that is hypokalemia, or maybe type 4 RTA, that is with the hypoaldosteronism with hyperkalemia. We need to treat them accordingly. BP check is a must because they might have hypertension, they might have urine, and all that accumulates to the add-on renal dysfunction. So we need to check because creatinine derangement is far late effect. These are much more earlier effect. if we catch them early, we can halt the derangement. We can't reverse it, but we can halt the derangement.
So many children will have poor growth even when their creatinine is normal because they are having salt wasting, fatigue, etc. We need to check BP, we need to check protein creatine ratios for proteinuria and treat with these inhibitors as necessary. Okay, then coming to the management of bladder dysfunction, we'll have to be very briefly about what is available.
Yes.
Medical.
Yes, definitely, ma'am. The medicine we have has been very well summarized. We have got anticholinergics like oxybutynin and all. We have got alpha blockers in the form of tamsulosin, which are mostly specific alpha blocker, and terazosin also. The most important, the newer kid in the block is the mirabegon, which is a beta-3 agonist, which has got action in both of the bladder and also to some extent as sphincter. Now we cannot use all the things together. The medical indications, the urinary bladder, the ultrasound, and even the MCG guides us. Suppose if there is an overactive bladder from the bladder diary, then anticholinergics will help. But if there is a significant detrusor or sphincter dyssynergia, then the alpha blockers along with others will.
Would you like to talk about drainage, bladder drainage? Just the options.
Despite medical treatment, if it fails, or maybe in add-on, or if there is a repeated infection, the bladder is ongoing bad, we might sometimes be off for a CIC. But remember, before doing clinical theoretical, there is a possibility that this kid might have a same bladder, but usually under follow-up might not have also, they can easily tolerate also. For some infants who have a small capacity bladder, doing CIC 10 times or 20 times is difficult. Many times they will have the polyuria only at nocturnal time. So that time a overnight drainage can also help, provided they allow the catheterization to us despite their sensitivity.
Sorry, I lost that. So, Dr. Kuntal, let's go to surgical options of bladder management. What are the surgical options if medical therapy fails? Or
We
if
can
there is
give-
something that cannot be treated with?
We can give Botox injection. Botox injection can be given in the bladder wall to relax the bladder muscles, and also it is injected in the bladder neck at 3, 6 or 9 o'clock position to relax the outlet of the bladder. Bladder neck incision has been described by Dr. Basu. Bladder neck incision can be given, but we should remember that bladder neck incision is an irreversible procedure, so we should not opt for bladder neck incision
Is
too
there any
early.
guidance on how early we can do it?
Yes, some centers prefer bladder post fulguration and bladder neck incision in the same sitting, but we do not. There are some risks like retrograde ejaculation, urinary incontinence. These are reported.
Which will be there even in adulthood.
Yes, in adulthood. So we should first try with an alpha blocker. Then, if it is does not subside, then we can give bladder neck incision. And of course, bladder augmentation. Bladder augmentation we do if there is a small bladder, if there is a high pressure bladder, even after anticholinergics and
Again, earlier
CIC.
stage.
Not before 4 to 5 years of age. We can do augmentation, but at the same time we do a nephro-uro channel, that is a continent catheterizable channel in the anterior abdominal wall, through which we can introduce the catheter, because urethra is very sensitive. So with bladder augmentation along with nephro-uro procedure. And viewer surgery reimplantation we prefer that is also not before 4 to 5 years of age. If there is recurrent UTI persists or if there is PUV obstruction persists, then we can go for a reimplantation procedure.
But we have to treat the bladder first. Make
Yes,
sure
we
that
have to
the
treat the bladder first, and we have to do a urodynamic study to see whether there is bladder is stable or not.
Okay, we had a few patients which I'm going to not present because many patients have been presented. So this was a child who had fulguration and then had some straining, etc., and was found to have residual valves. This is a patient who at the age of 14 or 15 years had some urinary, did not have any urinary symptoms, but an ultrasound was found to have increasing dilatation and was found to have bladder neck that was not opening and improved remarkably on alpha blockers. So I'm not going to go into detail. Last case, last slide. This is a patient who with PUV who was accurately detected, who had severe involvement with oligohydramnios, ventilated at birth, got PUV ablated on day 3, and he went into early CKD, and then I don't know if you can see this graph, his creatinine rose through his childhood and teenage years. Now he is 16 years old. He has been in ESKD for the last 3 years and he's on nocturnal intermittent peritoneal dialysis. He has never had a UTI, has a good urinary stream. So, what I want to just discuss very briefly as the last topic is these patients, what kind of pre-transplant evaluation and actions do they require?
Yes, a hostile bladder which has already damaged the native kidneys, there are high chances that even post-transplant it might damage the transplanted kidneys also. So as I previously said that I would like on bowel management and then definitely the bladder management. So after managing the bowel, if we do the bladder diary and we have done the uroflowmetry. Now the child is a 16-year-old child with apparently no UTI asymptomatic, but I don't know that the bladder diary is visible to everyone or not. If you find it that the frequency is around 6 times, so it becomes a normal frequency. But it's a 16-year-old child with an expected bladder capacity of around 500 cl. Now the average amount of urine the child is passing is around 200 to 300. So that becomes a lower capacity.
65% is not.
Okay. And the morning void, it's around 800 ml. So if I take as a 130% as a definition for nocturnal polyuria, so the child will be having a bit of nocturnal polyuria.
You take the morning void like representative of the night.
Yes. And regarding the uroflowmetry, apparently the child, the curve looks bell-shaped curve. But when we analyze the data over there, the urinary flow volume was around 113 ml. So personally, when I think that we might have a repeat uroflowmetry, and since there is evidence of nocturnal polyuria with a little bit of lower capacity, there could be some inherent bladder pressure issues. So personally, I will be going for a urodynamic set definitely, and definitely I would request Kumpal sir will be much better, will be able to provide on the benefit.
So definitely I think pre-transplant we would want a UDS or formal UDS. The child had an MCU first, okay. This is the MCU, so you can see there is bilateral, very high grade VUR remaining. So any comments about this VUR? Does the UDS findings, how will it determine your management of this VUR in this child?
There is high grade reflux, so before we can go for a deflux injection in this case.
But it's a non-functioning, both kidneys are non-functioning.
So we have to go for a nephrectomy.
Right. But the child is passing a lot of urine, and because he's on intermittent PT, we are able to maintain intermittent PT because he passes a lot of urine. That means we have to convert him to hemo.
I hope the rest of the bladder parameters is volume, pressure, overactivity, these are not there, no distal obstruction, no neck problem. That will presume only the reflux
So
is there.
from the UDS,
Likely for a PUV.
so such hybrid reflux, we would expect that the bladder pressure, there must be something wrong, right? Kunal, any comments?
Volume every time might be overactive.
The thing is, if the patient is not having any UTI in the last 16 years, then we will leave the reflux as such.
Okay.
Because anyways the kidneys are not functioning.
But we would do a UDS to confirm that the pressures are normal.
Yes, UDS would be necessary in this child because he is going ahead for transplant. We need to see that the transplanted kidney will be safe.
Okay.
Just for that, we need to look at the bladder pressures.
Okay.
Already the uroflowmetry volume is 100 ml. Daytime volumes are 200 to 300 ml, and the reflux is still persisting. It means that probably the bladder is still high pressure.
Okay.
In that case, the bladder management would be required before the transplant. So we need to do a UDS in this case.
Okay.
Can I make a comment?
Yes, please.
This patient has got grade 4 reflux. He has a high grade reflux. And this patient is going for urinary transplantation. So the kidneys will be removed. What can be suggested is that we use the lower ureters for augmenting the bladder so that it becomes a larger capacity bladder with low pressure, and then implant the transplanted ureter into that augmented bladder.
But I think that depends on the UDS findings.
Yeah, this bladder will be on the high pressure.
800 ml of the arch.
800 ml once in a day, but otherwise
He's not drinking. See, if you look at the total intake output, it's almost equal.
Yeah, but
So that volume might increase if we let it drink more.
no. This bladder is a high pressure bladder.
और यूडीएस हुई थी कि नहीं?
I mean, which हाँ बोले देखिए भी था.
UDS এ যদি হাই প্রেসার দেখায়
हाँ
এর একটা ইরেট্রোনিওসিস্টোস্টোমি করে দিলাম
okay আর যদি না দেখে
না দেখায় তো go ahead and do whatever.
with the reflux as it is.
Let
Okay.
leave it.
So we will do the UBS in this time. So final question is that it is very easy for these patients to drop through the net, especially in government hospitals where a large number of patients are being seen. So should they be handed a protocol saying that these are the marked dates at this stage, this stage, this stage you need to come and do this, this and this. So this is a follow-up protocol from your group, from the Indian Pediatric Surgical Group. But I think this protocol is very aggressive, and probably any of us do not do this. There are other protocols. This is the Great Ormond Street protocol, which is slightly less aggressive. And I think that the message we would like to sort of end with is that we should, in our minds, be clear that some things we should do very regularly. Initially 3 to 6 monthly, subsequently maybe yearly, which is history, clinical exam, measure the growth, the weight, blood pressure, renal biochemistry, ultrasound. In non-toilet trained children, 4-hour voiding observation. In toilet trained children, the voiding diary, uroflowmetry, urine PCR. The latter may be yearly. So I think these things we should have some protocol, which we don't have. We do not have a consistent protocol which is followed by everybody. So all these things I think should be done regularly, and then depending on these findings, we decide what to do further. MCU cystoscopy, as Dr. Kuntal has said, maybe if things are going down certainly, but maybe once in follow-up to make sure there are no residual valves. DTPA maybe for a baseline, this is controversial. DMSA, if there is B-word, UTI maybe as a baseline, and then UDS, if invasive UDS, I mean, if there are abnormalities on the non-invasive screening. I don't know if you will agree to all of this.
So my question is if we are doing check cystoscopy, do we have to do a MCG also?
We can do MCUG.
If we are doing
I don't know.
Yes. We both. If the symptoms persist, we do both. The advantage is we can see whether there is a stricture, whether there is residual valve, whether there is a structural anomaly like diverticular.
But stricture, residual valve, you will be able to see.
Yes, whether there is a large diverticular present or not. We can see, but we can.
Reflux can be seen
and
better.
the grade of the reflux.
Even reflux also apparently you people can
But the grade of the reflux, whether it is subsided, grade 5 to
because
grade 4.
at least in the Western world, I think they have stopped doing repeat.
I think I would say again, if each child is different,
Yes.
we need some method to check that there are no residual valves,
That's
because
okay.
repeatedly we find residual valves coming up. So some method should be used, and probably depends on case to case
Yes.
which one.
Definitely MCG is optional, not in every
But
case.
the radiation involved in the MCG.
If clinically everything is well and these initial investigations are fine, we just done one check MC that. So
Then we do not do MCG.
Then no further radiation, and cystoscopy also might
Because
be
there
So
are
there's if you look at the literature, there's
So
a
how
lot of
stable is the patient?
on
That was-
MCU findings. There are dilated, there's measurements of bladder, urethra, and what is matching with what prognosis, etc. So the group that goes for MCU says that has several advantages, but there's a major major radiation chance of UTI.
Okay.
The cystoscopy group again says less radiation, but invasive, general anesthesia. So there's plus and minuses. And
because there
often
are
can be-
institutions which have in India which are doing yearly MCG.
I think that's probably
Are we
not.
doing DRCG?
And
DRCG or contrast
That would
ultrasound
include
related
less
reflux
radiation.
can be done.
Yeah, but that's
But less commonly available, that is the problem. Expertise to report that one and availability is also not.
I have a question for this learned gallery.
DRCG is very clear. DRCG is useful only if you are wanting to look for reflux.
Yes or no? quantity.
Yes or no?
Certain quantity.
It can be great.
So in this sort of a situation, DRCG
Because you want to know the urethra, you want to know the bladder, DRCG won't tell you anything. Yeah.
Now, if we combine DRCG with cystoscopy, we can avoid radiation.
No, DRCG is still radiation.
Devlin is asking if some center is trying MCU plus cysto, can they opt for DRCG and cysto?
But are we so interested in reflux?
Yeah, that's
We are more interested in bladder, isn't it? You want to bladder first, then you are thinking reflux will go away.
I think good voiding diary or 4-hour voiding observation can give us very good idea about what we are dealing with. If we have high frequency, even if the parents say that the voiding, the flow stream is very good, that usually the parents say the stream is very good. But if the voiding diary is showing high frequency, small volume, or the voiding frequency, the 4-hour observation, even very young children, is showing very high frequency, it means probably we are dealing with some overactivity over there. Or and suppose we do a UDS, we are finding overactivity. Then probably we should go ahead and check why is the overactivity there. We cannot just treat the overactivity. So in that case, MCU becomes necessary to look for whether there is any subtle bladder neck hypertrophy. The bladder neck is not opening. There is some subtle narrowing over there. It may be a stricture. So if we are seeing a stricture on the MCU and then we are going ahead and doing a cystoscopy, many times what happens is this scope is very thin. So that goes inside the urethra. Very subtle strictures, and that portion of urethra is not distensible enough. So that may be missed even if we are doing cystoscopy. If we have an image of the MCU in front of us, okay, that there is a narrowing over there, so we may evaluate that area with that point of view, and then we can do a dilatation. So it's the whole patient as a whole, rather than one investigation per se.
So every patient is
Yeah.
So
you can check a video at least, so that many times mom says that.
So related question to Poonam. We have seen many case presentations during the day. Not one talked about the 4-hour voiding diary, even though there were infants reported. Can you tell all of us? We don't. You didn't remember. It wasn't mentioned in your presentation.
we are doing it in our clinic.
It was not mentioned, so we don't believe you. So can you just tell us what it entails? No.
Okay. So 4-hour voiding observation, actually that has been told about in the literature is the child has to be kept under observation, a trained sister has to be there has to be diaper, and every time the child is passing urine, the diaper will say that okay, the child has passed urine, either the color sensors or something, and then after that the diaper weight has to be taken.
So you feed the child first?
Yeah, the child will be under observation, playing around with the diaper.
Okay.
And the child is doing routine activities, drinking and everything. And whenever the child voids, the diaper will give us an alarm if the child has voided, and the voided volume will be seen.
You don't have that alarm thing.
No, those things are not.
So, so that is like how it has been done in
That's the ideal thing.
But we are doing it. Poonam can again say that, but we are doing it.
So what we have been doing in the OPDs, we just ask the parents to check any 4 hours during the daytime whenever the child is awake. If the child falls asleep in between, they have to note down at what time he has fallen asleep. So whenever the child is awake, those 4 hours, they'll just put a tick. How many times the child has voided. The child is supposed to be there without the diapers, so that somebody can observe the stream. If he is passing urine in fractionated stream, they have just mentioned how many fractions the child is passing urine in.
Take a video also.
If possible, take a video.
No. Nowadays we are making it mandatory. Like everyone is having this.
I think the idea is a little more. It should give you a little more information, because what you're supposed to do is after every word you're supposed to check for PVR.
PVR also.
And you're supposed to document a 5 ml or less PVR at least on one occasion.
That is very well done if you are admitting that, like in our.
Yeah, obviously. I'm not admitting, but at least 4 hours a day.
Some sort of a daycare.
But that becomes that is practically not possible in most of our setups.
We would have to do it in villages center.
And the amount that has to be charged ideally then. So one practical way is just the parents just keep a record of, we can get an idea about the frequency, and the parents can also give an idea about whether the volume is small or large.
Anyway, often have interrupted stream, totally normal. They pee in little bursts. They do incomplete feeding. So if you don't do,
but still, if you,
that's why they say in 4 hours at least one PVR of or less in 4 hours. That's why. So oftentimes we do not pass the full urine in one complete stream. So If you don't have the full information, I think it's very
No, I don't think
confusing.
no point in arguing. Like we don't have, we completely agree. We don't have the ideal thing, but that we are at the
If you
moment.
talk to normal parents, if you think about your own kid, interrupted stream is very common in India.
So what we are saying in our like in the bladder clinic that we run in Manipal, previously with the Poonam, now she has left us, is that we are now saying that at least do it over 3 to 4 days, 4 hours, 3 to 4 days. Just and during that, at least 4 or 5 videos of the thing and how many time frequency. That gives us some idea. Just not ideal, but ideally we should be starting it because
You should.
because what I am trying to emphasize is, and Poonam will also agree to that the Western world and is going away from the MCG and the UDS. I was also surprised. Like recently, I gone to the ESPN and in the guys now they have a bladder consultant. There are 3 consultants who are looking only after bladder, nothing else.
No, sir, they
Portable
are
ultrasound
Previously they have got, now they have got 3 bladder consultants. So I was speaking to them about like how much the UDS you do, MCG you do. The number has come down drastically. When I started training in Great Ormond Street Hospital, they were doing UDS on everyone, and I also came up with that sort of idea that no, why not do a UDS in 3-month child? Because we have been shown that now they are going away from that.
So I think we will end. Thank you very much.
Before you went,
Oh, sorry, no.
sir, I have a question.
अभी thank you बोले भी था.
No, I'm आगे question का पढ़ेंगे. There are very large people on posterior valve. I just want you to ponder on something. Posterior valve are very small things. They do not even close the whole of the urethra. And at times when you keep doing repeat cystoscopy, we always find some amount of valve here or there. They are very small things. How such small things
That was my question also.
can give rise to so much amount of changes, pressure changes, and renal failure. Ponder on it.
Actor Jinish बोलूँ.
Are we missing something?
But I have seen studies on. But residual valves does not necessarily mean obstructive valves.
That's what I'm saying. But
Can
they
be just
are.
remnants.
But there are obstructions.
So
and
we
where
won't
this
know if
obstruction
there's-
is coming from.
But we won't know if there is obstruction until we do uroflows and UDS and all that. Follow up evolution. During follow up.
I'm talking about the whole thing. Do we understand posterior valve?
No, we don't.
We don't.
Like
There is
most,
something we
like
are
most
missing.
things.
And I request this way. A lot of you know a lot about posterior valve. Please think about it. Are we missing something?
So thank you first to my panelists for a great job. I'm sorry that your role was a little bit curtailed because everyone took away your roles from you. So, but
We are still crossing
care
our
of.
time. You know,
I also want to thank our pediatric surgeons, our radiologists, without whom we cannot take care of PUV. And a big thank you to Dr. Poonam, who has really opened up the world of neurodynamics for all of us.